Good morning, everybody. My name is Tamsin. I'm the matron for the Liaison Hub and the Discharge team at Oxford University Hospital's NHS Foundation Trust. I'm here this morning to talk to you about Discharge to Assess and specifically Oxfordshire's journey. I must preface this by saying that Oxfordshire's journey is by no means complete or over. It has been a very challenging year for everybody, really, and I think that we have been able to demonstrate the art of the possible whilst contending with the gravity of the situation that the health and social care system has faced. The case for change is well documented over the past few years by campaigns such as End Pyjama Paralysis and The Last 1000 Days to Live. The financial implications are clear. The longer that a patient spends in a hospital bed and the more that we assess people in the wrong place and at the wrong time, the higher the financial cost of the long-term care provision. Oxfordshire discharges too many people on pathways 2 and 3. We are working and have been working on a shift towards discharging more people on pathway 0 and pathway 1. This will facilitate better outcomes for the patients themselves, but also in turn will make financial savings. There have been a number of publications over the past 12 months. These are documented on the slide and the links. They give recommendations to health and social care systems as to how to take action and how everybody can work towards the change and implement the recommendations within those guidance. The key points for action are criteria to reside, so acute hospitals must discharge everybody who no longer meets the criteria to reside as soon as they're clinically safe to do so. Enable for systems, in order for systems to be able to do this, they must fully embed a discharge to assess model for both home and bed-based. Short-term care post-discharge should be therapy-led where appropriate, and assessments for long-term care provision should happen after a period of recovery and rehabilitation. There should be a home first ethos instilled into the working practice of people, and most of this discharge to assess service provision should be supporting people in their own homes. A small minority will require a short-term bedded facility. These actions for change can be reflected simply during board rounds and patient interactions with the question, why not home? Why not today? In terms of our Oxfordshire pathway and our Oxfordshire service, we set up Oxfordshire Home First Service last year. There was a system lead appointed from the local authority. She's an incredibly passionate and driven individual, and she is excellent at working collaboratively. I have got a lot of respect for her and really enjoy working with her, actually. The aim of our Home First service is to support people to go home as the default pathway. Reablement resources are mobilised and, where appropriate, in conjunction with rehab and voluntary sector involvement to facilitate the best outcomes for our population. The project group that we established has got partners from community therapy, the local authority, the acute trust, so myself and also an acute physician. We have input from community hospitals, teams, reablement providers, and the voluntary sector. The voluntary sector have been absolutely invaluable with their input and their approach to the patient and the next of kin conversations, discussions, and bringing their views into our work and how we develop our service. They have achieved big gains as well for us, so they have made some real improvements in redirecting people from pathway 1 to pathway 0. We have some work to do with more including our acute hospital at home colleagues and our community nurses. We have higher level meetings which happen weekly with our system leaders. That also has representatives from commissioning and from GPs. We developed our pathway using the national guidance, and we agreed it at a system level, and we started small. We felt that we needed to kind of get it right first with a small cohort before we went big bang, so to speak. So we started with a small number of postcodes within the county, and then we built up gradually over a 4-month period to become county-wide. We established a virtual MDT, multidisciplinary team, which has been incredibly useful, and I think goes back to what I was saying about the art of the possible. I'm not sure that any of us would have thought a year or more than a year ago that we would have been able to facilitate such working virtually rather than actually face to face. Within our virtual MDT, we have a shared vision which we've developed through working together. It's enabled us to effectively use our resources, which is reducing duplications of, with regards to referrals and assessments, etc. Clinical governance has of course been very important, but yet again a kind of shared approach has led to a greater understanding within services of the different pressures, and we've had some joined up working to find solutions. With regards to patient engagement, we've developed a patient information leaflet. We also have a feedback questionnaire via I Want Great Care. And most importantly, we've had weekly case studies, which we bring to our weekly meetings with our system leaders. And this is to really remind us of why we're doing it, and to kind of demonstrate good and bad, so the case studies have covered both, so that we can learn and that we can continue to develop our service. In terms of our process, the patient map there is kind of what happens to the patient. So essentially we have an agreement from the MDT about the pathway. There is a 10:30 meeting each day to allocate resources, and there's also an MDT at 12:30 each day. We then discharge the patient. Once they're home, they're met by a reablement assessor and a therapist from Home First. They do the initial assessment within the patient's home, and build the support package around that patient. Once that initial assessment has been undertaken and the kind of care and etc. has been set up, then we move on to a 3-day review, see if there's anything that needs to be amended, changed. That then moves on to a 7-day review, and that is repeated until the patient has completed their reablement episode. At that point, the patient is either discharged independently, or at that point, once they've had that approach, that opportunity to rehab, to reable, to recover, we do the assessment for their long-term care needs. The performance of the service, so the overall median length of stay within the service is 22 days currently. However, as a system, we wanted to understand the difference between the length of stay of the patients still receiving the reablement intervention, and also those who had completed their reablement intervention and were waiting for a long-term domiciliary provider to pick up that long-term care need. This is what we call contingency, and we felt it was important to establish the length of stay of each of these to understand. In terms of outcomes for patients, we've done exceptionally well. So throughout the service has managed to meet the national target of patients being discharged with reduced ongoing care or no ongoing care. So again, our recent figures reflect that 76 of people have been discharged in April, and that has been either with reduced ongoing care, which is 10%, or no care, which is 66%. In terms of patient feedback, it has been overwhelmingly positive throughout. I have some examples of our most recent feedback, which is from March. I think the key messages that really stood out for me within these were the messages about treating people with dignity, with kindness, building their confidence post-discharge from hospital, and also having the patience to support people. It, as we all know, can be a big change for people to be discharged from hospital, to suddenly be alone again in their own home, or kind of with basically not the opportunity to just press a bell and have somebody there to attend to our every need. So it's we've had some really great outcomes, and those patient messages meant a lot to the team that have been working with them. In terms of challenges, and let's be honest, our journey has not been without challenges. As I previously referenced, as a system, we have always been overly reliant on bed-based care and bed-based solutions. We do discharge people, too many people, as I've previously referenced, to pathway 2 and to pathway 3, and we need to make that shift to pathway 0 and to pathway 1. As I said, we've been working on that and we haven't quite got there yet. That is why our journey is not yet over. We initially struggled to provide access to patient information for some of the stakeholders, including our voluntary sector, and this increased other people's workload to kind of counteract the fact that they didn't have access, and it also risked information not being documented in a timely manner. We've since overcome that. They have access to our system, which is wonderful, and they are able to view what they need to view, but they are also able to document their interventions as and when they happen. In terms of resourcing, there has been a gap between the capacity within the services and also the demand for the service, and that is mostly from a care provision side, but it also relates to therapy as well, and that is something that we are also working on and that we monitor at our weekly meetings, and we are slowly bridging that gap. There are multiple IT systems. I'm sure you're all familiar. So as an acute, we have one IT system, the community provider has another system, the local authority has another system. Unfortunately, we have not been able to go so far as to all being on one system. We haven't even got as far as getting our systems to talk to each other. However, what we have achieved is we've managed to give access to each other to all of the different systems. And again, this has made a massive difference in terms of reducing the duplication of assessments and sharing information, and I think therefore has hopefully had an improve for the patient, because I know I have heard patients and relatives say before, you're the third person to ask me this same question about, you know, where do I live and what's my house setup, etc., etc. So it's been a really good move that we're all able to access each other's systems and to see the information that is already there towards helping us to plan people's care. In terms of the day-to-day coordination, that has been a challenge because, again, we have multiple services that are involved in our Home First service. As I said, there's community therapy, there's the reablement providers, there's the voluntary sector. And of course, all of these services have competing priorities on a day-to-day basis. There's been the challenge of being able to accommodate the planned and the unplanned demand, and also to accommodate changes and delays. So you have a setup call at a certain time, and unfortunately something prevents the patient from being able to be there at that setup time. That then has a knock-on effect for the rest of the day with all the other visits that are planned, etc. It's been very interesting looking at the parity of practice and actually sharing skills and knowledge across the various services. I mean, having acute therapies, community therapies, etc., all kind of working together, sharing their skills, sharing their competencies, etc. And that, so I think, although it started as a challenge, has now become one of our biggest achievements, really. The other thing that has been a considerable challenge for us is the fact that we, up until now, have not had a specific commissioned resource to support the delivery of the Home First MDT. So we've got specific commissioned resource in terms of providing the care, etc. But the MDT support is basically everybody doing it on top of their day jobs. So that has been quite challenging, and I think goes back to what I was saying about the day-to-day coordination and competing priorities, etc. But again, that is something that we're looking to specifically commission and protect that resource and that support. In terms of bed-based discharge to assess, at the moment what we have within Oxfordshire, our continuing healthcare team spot purchase beds for us in care homes across the county to meet the needs of individuals. So if we have a patient who has particularly complex, challenging needs, then CHC will spot purchase a bed that can meet those needs for us. We'll transfer that person to that bed. They will be given an opportunity to recover, recuperate, and CHC will assess them once they've had that period of time. We also have short stay hub beds, which are block beds procured in nursing homes across the county. There is an MDT that supports those patients in terms of discharge planning, therapy, social work, etc. And we have a trusted assessment referral process in place to access these beds 7 days a week. At present, the average length of stay is 26 days, and 78% of these patients return home, which again is great outcomes. They were significantly affected during the pandemic and by COVID, with outbreaks and restrictions to accessing the homes, etc. While we were in that period of time, the local authority very kindly made contingency plans and procured other alternatives for us using the funds made available. Our next steps. So, as I said, our journey is not over. Firstly, there are some discrepancies within the pathway reporting across the country, apparently. I've had conversations with people from another trust, and my boss has as well, and it's interesting that actually where you think the pathways are clear, there are margins where certain things are getting reported differently. So we're trying to just seek absolute clarity on what should be reported in each of the different pathways. This will ensure that our data is 100% accurate. We don't think that it will change our overall aim of a pathway shift from the 2 to 3 to the 0 to 1. We think whatever changes are made will be within the margins. We also need to work on our transition from the prescribing model to the describing model. Acute teams have really struggled with this. They felt quite criticised for being too risk averse. They get challenged when they overprescribe. They get challenged when they underprescribe. And so they've struggled with this. So it's something that we need to continue to work on. In addition to that, actually, the providers, the reablement providers, have really struggled with the idea of not having a prescription, so not having a prescription to plan their capacity to. And so kind of say, well, if we don't know what they're going to need until we get them out, what if they need 4 times a day double-handed, for example? So again, we're trying to just work on those issues. We also know that evidence has shown that areas where this has been really successful, it has been because community teams have proactively taken the responsibility to pull patients out of the acute and make the appropriate pathway determination. So we are currently transitioning to this pull rather than push model. To increase efficiency and to reduce duplication, our local authority is streamlining the Care Act assessment to provide a seamless transition post-recovery and rehab. We also have noted that with regards to the delirium pathway, too many patients go to bed-based care for delirium, whereas we all know that they would recover better in their own home. So we're looking how we could support this cohort of people through our Home First team, whether there's specific services that need to be commissioned in addition. One of the biggest blockers there is actually quite often the family anxiety. The other thing that we need to do is we actually need to review the capacity and demand for Pathway 2 beds and develop a specification in line with the national guidance, because the beds that we have at the moment, the short stay hub beds, etc., they weren't ever commissioned or set up specifically to be a Pathway 2 D2A bed. So we need to make sure we have a clear definition and description and specification for what that type of bed looks like. And we also need to establish what Oxfordshire's demand and capacity is for that. I'd just like to say that I'm actually very proud to be part of the Oxfordshire system. We have engagement at all levels to implement the recommendations, make changes required for our population. We have multiple opportunities for patient level discussion and also for more strategic themes to be discussed and for us to learn from. There is a high level of mutual respect between services, and there is a list here of the different opportunities that we have on a daily basis to interact with each other and to make plans. Thank you for your time, and if there's any questions, I'd be happy to answer them.
Thank you very much for a really, really interesting presentation there, Tam. Sounds like such a great idea, especially given so much that I read about people, especially older people, being stuck in hospital beds. We've now got around 10 minutes for questions, so audience, please send them in via swap card and I'll pass them on to our speaker. And also, don't forget to tweet about your experience with the hashtag NT Patient Flow. And you can also use the chat to the NT team function for help as well. Now, I'm delighted to say we've already had some questions in. So, Tamsin, if you're ready, first one is from Nadine Rooney, and she asks, well, in fact, she says, "I wondered how you have overcome the access to patient information from the voluntary sector."
Okay, well, I mean, essentially, we worked as a system to ensure that there was kind of governance arrangements in place for us to be able to share information with them. And once we had kind of a whole system governance structure that had been signed off by our senior leaders that gave authorization for them to access the patient information, etc., then it was just a simple kind of getting them the honorary contracts with each of our organisations, so the acute, the community, etc., and getting them, access to the system like we do with other honorary contract people. So yes, no, it was a really, really good move, but it was not. It was. It took some time, shall we say, to get the kind of governance all agreed and signed off at all levels.
I can imagine. I can well imagine. Yeah. Great, thank you. Amy Bromwell, she asks, do you work against any standard operating procedures or criteria for which sorts of patients will be safe to access the Home First system? So some quite technical questions coming in.
Yeah, definitely. So we, it's quite funny actually. So we've kind of we've had a number of different criterias over the kind of period of time that we've been running the Home First service. I think we started off being quite kind of strict in the criteria in terms of kind of who we felt should be accessing it, and then we realised that actually really we want to get as many people home as possible. That's the whole message that we're giving, isn't it? Really, is home first. And so then we kind of went it out, and basically, it's anybody that we can possibly get home with support, we will do. The only people that we don't support via Home First is really the people who already have some sort of domiciliary provision in their own home already, and actually that just needs tweaking in order to get them home. But in that case, sometimes we might use some of our therapy provision from the Home First service to support the domiciliary care provider. But what we won't do is just use our reablement resource for that patient specifically. Because it's better to use the agency that they're familiar with, if that makes sense. But yeah, so we have got standard operating procedures. We've got a criteria kind of written down, etc. So I'm quite happy to share those documents with people if they want to connect with me. That's not a problem. But yes, as I said, we kind of started small and then actually went, hold on a minute, everybody should be able to access this. Anybody we want to get home. Home first is the message.
Fantastic, thank you. I think that the next question quite well reflects the challenge you highlighted with the computer systems talking to each other. So Mudasir Nadeem Pasha ask, are there plans for a computer system which will integrate all those technology systems? They say this should be discussed nationally as well. I'm sure that would be the holy grail, getting all those computer systems to talk to each other.
I think it really would be, wouldn't it? I mean, everybody that I speak to in all the different systems, it's such a common theme. We've all got different services in each of our counties, and they all have information about our population. And if only we could kind of join it all up together, you'd have a beautiful kind of overall summary of that patient. So yes, I mean, what we are looking to do is kind of we are looking to see if there's some way of having kind of one platform in terms of the referrals for the discharge pathways, and whether that platform would be able to kind of pull information from each of our various systems. Because obviously we don't want poor, very busy staff who are within the hospital having to type out kind of demographics and things that are already within our system. So that's kind of we've got our our IT leads from the county, kind of looking at all the different options that we could use. It's something that would definitely revolutionise the way that we work.
Yeah, fantastic. I can quite imagine. Really, really would. So Tanya Knight, she asks, Could you tell us a bit more about the daily huddles?
Yes, of course.
I
So
guess.
essentially, yeah, so it's every single day, 7 days a week. It's chaired by the discharge team who I manage. And essentially, we have what's called a kind of ready for discharge list, which we oversee every single day. And at the daily huddle, which is at 12 o'clock each day, we have representatives from social services, from continuing care, from Home First, from community hospitals, gosh, who else? Embedded housing worker, trusted assessor, kind of everybody who is involved with trying to support us to discharge patients. We all come together. It's it's a teleconference essentially, and we literally go patient by patient. So literally every single person who is on that list that is ready to go is discussed, so that there are clear actions and we're holding holding people to account, if that makes sense. If they're kind of for a certain pathway, when is that person going to move on, essentially. And also it just gives some great kind of cross discussions between services, to kind of iron out any, well, again, it gives that opportunity to share information. So if somebody is known to a different service, then they are able to say, oh, we've just had this person and we can tell you this about them. Or it will be an opportunity for discussions about who's going to be kind of taking, whether we're going to be altering that patient's pathway in any way. So, if they're down as being on one pathway, it's an opportunity for us to say, actually, no, hold on a minute, we think that they'd be better on this pathway and we can take them tomorrow. So yes, it's honestly, it's probably the most helpful conversation that we have every single day. And my vision with and not my vision, but our vision, with our transition to the pull rather than the push model, is essentially having that style of discussion, and moving it to a all day every day discussion rather than just one point in the day, if that makes sense. It's about kind of
That's
getting
great.
all of
And
those partners in the room together. That is going to be that will be our pull team, and they will be in a room together, whether it be virtual or physical, depending on kind of how things progress. But and that will be our kind of move to a pull model where they can be having these conversations all day, every day, and actively pulling people out of hospital.
that's fantastic. Actually, just shows how interested people are in your session, because we've got tons of questions in and we've only got a couple of minutes left. So I might have to pass the questions on to you, if
Yes,
that's all right for future answering.
yeah.
So we'll go to another one from Maria Swift, who says, "Thank you for your talk. In regards to the referrals, are they sent directly to the ward, from the ward to your service, or do all referrals go via a quality and control hub?"
So at the moment, what happens is the referrals are sent by the ward, to the service, but we as a discharge team also get a copy, if that makes sense. And so there's kind of, so basically the referral goes from the ward to the Home First service, and it also comes to us. And so there's a double quality check, really, because we as a team will kind of review and see, if that's appropriate, if there's anything else that we need to do to kind of support that. And then also the Home First service themselves have a screening mechanism where, as soon as the referral comes in, they look up all the information, see if there's anything else that they need to know, or so if there's anything that they need to know that they don't feel is on the referral, they'll go back to the ward to ask for some additional information. Or, as I said, that they might bring that person up at the daily huddle to say, this referral's come through, actually we're a bit unsure about XYZ, could somebody from another service kind of provide some clarity for us? Or they might ask us as a discharge team at that point to kind of go back and do a bit more work.
Fantastic. Thank you very much, Tamsin. I'm going to have to stop you there. As I said, we've got loads more questions, but we've actually run out of time. As I said, fantastic presentation, a really good one to start off with. Thank you very much for your time. So, the session is a short showcase presentation from our sponsor, Galen. We've introduced self-administered painkillers to save patients time at Royal Victoria Hospital Emergency Department. So please welcome our speaker, who is Kelly Doherty, an advanced clinical practitioner in emergency medicine at the Royal Victoria Hospital in Belfast. Thank you very much.